Good morning, everybody. So it's Monday, and we are starting in on the spinal injuries. So this is going to come in two parts because there's a lot of information, there's a lot of injuries, and then also the spine is in different parts. So today we're going to cover, today I'm going to do all of the spine, but I'm going to upload it in two videos for you. So the first one that we're going to look at is cervical spine and thoracic spine. We're going to do those two together, and then the next slides and the next video that I'm going to do is going to be the lumbar spine. As athletic trainers, we deal a lot more with lumbar spine injuries, and so I want to do that one by itself and be a little bit more inclusive for that one. For cervical and thoracic spine, we're going to go through it pretty basic. There is a lot of material here. There's a lot of injuries that can happen. More than likely, these are going to be emergency situations. And so there's not a ton of assessment and rehabilitation that goes in with these, but you need to be aware of these injuries. You need to know what you're looking for. So we're going to go through. I'm going to go, we're going to touch a little bit on the anatomy, but we are not going to go super in depth. There's a ton of ligaments. There's a ton of vasculature that goes through the spinal cord or the vertebral column, and so that's all stuff you should have covered in anatomy. There will be some pictures and things like that throughout the slides, but I'm not going to go super in depth in anatomy here. We're going to cover the segments of the spine and curvature of the spine, but we're not going to go into the anatomy of a vertebrae or the facet joints or things like that. So just there's your overview, and let's get started. Again, there's slides we're going through. I'll let you know what slides we're on, and then it should flow from there. All right, so we're going to go into the slides on slide 2. So we're going to set you straight on the curved vertebral column. Let's see here. I had my page. There we go. So the vertebral column runs nearly the full length of your body. It begins within the skull and extends down into the pelvis. As a section of the body, it contains a large amount of bones, 33 altogether. The vertebral column is made up of vertebrae, and then each vertebrae is a separate bone. An important purpose of the vertebral column and all of its bones is to protect your spinal cord, which is the lifeline between your body and your brain. Nearly all your nerves are connected directly through networked branches, and those are connected to the spinal cord, which runs directly into the brain through the opening in the skull called the foramen magnum. If you look at the spine from this side, you notice that it curves 5 times. So we're going to go on to, let's see, we're going to go into slide, I think this is slide 4, yeah, curvature of the spine. It curves 5 times. It goes outward and then inward and then outward and then inward and finally outward again. The curvature of the spine helps it absorb shock and pressure much better than if the spine was straight. A curved spine also affords more balance and better distribution of weight of the skull over the pelvic bones, which is needed to walk straight. A curved spine keeps you from being too top heavy. And then each curvature spans a region of the spine. So we have cervical, thoracic, lumbar, sacral, and coccygeal. The number of vertebrae in each region and some important vertebral features were given to you in the slide 3. So I did that a little bit backwards, but you can go back and look at that table and see where each of those regions are. Again, on here, on slide 4, we have a picture. We have lordosis and kyphosis are the names of the curves of the spine. So the lordosis curve or lordotic curve occurs in the cervical and lumbar regions, and then the kyphotic or kyphosis occurs in the thoracic region as well as sacral. We are doing cervical and thoracic today, or in this video. So we are looking at lordosis and kyphosis. All right, so slide 5, we are looking at kinematics and major muscle actions. So kinematics is the study of the spatial and temporal aspects of motion, which translates to movement, form, or technique. Evaluation of the kinematics of a particular movement can provide information about the timing and sequencing of movement, which can then yield important clues for injury prevention. So this section we talk about kinematics of the cervical and thoracic spine, and we're identifying the muscle responsible for specific movements. The vertebral joints enable motion in all planes of motion, and they permit circumduction. The motion allowed between any two adjacent vertebrae is extremely small, so spinal movements always involve a number of motion segments. The range of motion allowed at each motion segment is governed by anatomical constraints, and those vary throughout the cervical, thoracic, and lumbar regions of the spine. So ways that the vertebrae are able to move depends on where in the spine they're falling. So we're looking at flexion, extension, and hyperextension on slide 6. So spinal flexion is anterior bending of the spine in the sagittal plane, with extension being the return to anatomical position from a position of flexion. The flexion extension capability of the motion segments at different levels of the spine varies within approximately 30 degrees, cumulatively allowed in the cervical region. Flexion extension in the thoracic region is restricted by the rib cage, with a flexion extension capability of only about 4 degrees in the upper thoracic segments, and then approximately 6 degrees in the mid-thoracic segments, and then up to 12 degrees in the 2 lower thoracic segments. When the spine is extended backwards past anatomical position in the sagittal plane, the motion is called hyperextension. People are flexible in different ways, and so one person's hyperextension might be way different than another person's hyperextension, which is different from other hyperextensions that we see in the body at other joints. So hyperextension of the spine is not going beyond flexibility or its movement point. It's just this term of past anatomical position. The range of motion for spinal hyperextension is approximately 24 degrees in the cervical region and 22 degrees in the thoracic region. There we go. So lateral flexion and rotation, movement of the spine away from anatomical position in a lateral direction in the frontal plane is termed lateral flexion. In the thoracic region, the cumulative range of motion for lateral flexion to each side is approximately 31 degrees, with 49 degrees permitted in the cervical region. Spinal rotation capability is greatest in the cervical region, with approximately 105 degrees of motion allowed between the base of the skull and C7. In the thoracic region, approximately 9 degrees of rotation is permitted among the upper 6 motion segments. However, from T7 to T8, or from about T7, T8, and downward, the range of motion in rotation progressively decreases. All right, so we've looked at motions of the spine, kinematics of the spine, and how those work. We talked about the curvature of the spine, so lordosis and kyphosis, and what that means. So now we're going to look into cervical spine injuries. For some reason, my mouse is not working. All right. Again, we're not looking at protective and preventative for this course. It's just there's a ton of stuff that goes into it. We're not covering protective gear or anything like that. So we're looking specifically at cervical spine conditions. And then we're on slide 7. So the relatively small size of the cervical vertebrae combined with the nearly horizontal orientation of the cervical facet joints makes the cervical spine the most mobile region of the spinal column. As such, this area is especially vulnerable to injury, and so we're going to go through a lot of different things that happen in this section of the spine. Again, we're looking at the cervical spine first, and then we'll go down to thoracic spine later in the slides. All right, so slide 8, we're looking at torticollis. So torticollis, or scoliosis of the cervical spine, is a deformity of the neck in which the head tilts to one shoulder and simultaneously the chin rotates to the opposite shoulder. So this is very common, well, not very common, but more than likely it's in babies. It is a symptom as well as a disease, and it has a host of underlying pathologies. There's many, many reasons that this could happen. Torticollis can be divided into two types, congenital and acquired. So infants who are born with torticollis appear to be healthy when they're delivered, but within 2 to 8 weeks, they develop soft tissue swelling over an injured sternocleidomastoid. Injury may result from birth trauma or malpositioning, or like the breech position in the womb. In children, acquired torticollis may result from trauma or be secondary to infection of the throat, the pharynx, or cervical cervical disease. In adults, the condition may result from a muscular strain, a viral infection, psychogenic etiology, vertebral or clavicular fractures, or traumatic unilateral facet subluxation or impingement. So again, in children, this is usually something that they are born with, and then in adults, it comes from an event that happens. So on the picture you can see, or on the slide I used 2 pictures of babies. And so we're talking about that sternocleidomastoid muscle, which in the bottom picture you can see where that muscle is. So that muscle is injured and it becomes extremely tight, which means that it's shortened. And so you're tilting to that one side and then your chin is going to the opposite side. So this muscle right in here is really affected there. So it's called wry neck, as a result of the muscular strain, often follows exposure to cold air currents or occasionally sleeping with your neck in an abnormal position, and this can lead to painful, tender cervical muscles. An individual can maintain the head in a position toward the side of the involved muscle to provide for a potential state of relaxation of that muscle. So that's why babies will instinctively just stay in this position, because that is where they're most comfortable. They're innately trying to figure that out. A ligamentous or capsular injury occurs when the neck is completely extended, flexed, or rotated, and the individual turns the head abruptly, which exceeds the yield point of those tissues. This results in a rotary subluxation when one or more pairs of facets move beyond their normal range of motion. As a result of this excess motion, the articular surfaces lose their physical relationship and they're jammed together, which results in separation of the anatomically opposing joints. All right, so signs and symptoms. First and foremost, we looked at how you can visually observe this torticollis. So the patient presents with the head tilted to one side and the chin pointed toward the opposite shoulder. So for example, if the head tilts right and the chin points left, the muscles on the right side are affected, and therefore range of motion is going to be limited. In addition, a palpable lump or swelling may be found in the involved muscle. So if you're feeling around in that area on an injured person, you'll be able to feel swelling sometimes. Management of these injuries. So in acquired torticollis, symptoms can usually resolve spontaneously within 2 weeks. Treatment is symptomatic and it consists of cryotherapy, heat, massage, supportive cervical collar, so they may have to wear a brace here to hold them in place. Sometimes muscle relaxants are used, and then interferential muscle stimulation and analgesics are used as well. Range of motion exercises can allow normal motion to be regained relatively quickly, and then continued care will enhance the ability of the individual to resume normal activities. My brother was actually born with this, so he had congenital, and so it didn't appear right away, and then we started taking family pictures, and we started noticing that he was always in this position, and so he went to physical therapy, and he is 21 years old, and nobody even knows. So this resolves very quickly if taken or if managed right away. All right, so moving on to cervical sprains. We're on slide 9. So again, we're looking at sprains and strains. These can occur in every joint in the body. Every ligament, every muscle can be sprained or strained. So we need to make sure that we understand the difference. Sprain occurs to a ligament, which attaches bone to bone. Strain occurs in a tendon or a muscle. So we need to think about that one a little bit differently, because I know on the test there was some confusion there. So the question was, a strain is an injury to a muscle, and this is true because the tendon attaches muscle to bone. So tendon and muscle fibers run together, and so they're always thought about as the same. So your Achilles tendon runs into your calcaneus, and so if you strain your calf, you also need to think about the Achilles tendon because they run together. And so that is why it is true that a strain is a muscle injury, because it occurs within those same fibrous tissues as the tendon. So sprain is a ligament, strain is a muscle and a tendon. We have to know the difference between those two because we're going to go through them in every joint that we look at from here on out. So I'm really going to get on you guys about that one because it's really, really important. No matter what field you're going into, whether it's athletic training, physical therapy, PA, even chiropractors, you need to know the difference between a sprain and a strain. All right, so on slide 9, we're looking at cervical sprains. Let's see here. Missed it. So cervical sprains typically occur at the extremes of motion or in association with a violent muscle contraction or an external force. Injury can occur to any major ligaments traversing the cervical spine, as well as the capsular ligaments surrounding the facet joints. So again, we're not going super far into the anatomy of this, but in the pictures you can see on this slide where those injuries are occurring, where those ligaments are. Minor activities such as maintaining the head in an uncomfortable posture or sleeping position can also produce a strain, a sprain of the neck. Signs and symptoms can include pain, stiffness, and restricted range of motion. Usually there's no neurologic or osseous injury in this case. Unlike cervical strains, the symptoms of a severe sprain can persist for several days. So management of this, you want to initially use rest, cryotherapy, and then prescribed non-steroidal anti-inflammatory drugs. So we're going to refer to those as NSAIDs from now on. And then you can also use the cervical collar for support. If they're extremely uncomfortable or they can't maintain correct posture, the cervical collar can sometimes help them be able to relax. Follow-up treatment may involve continued cryotherapy or superficial heat. In that case, it's whatever makes the patient feel better. Cold versus hot. There's really no evidence to show either way, so in this case we want to make them feel the most comfortable. So if cold makes them feel better, great. If heat makes them feel better, use that. There's really no there's no right or wrong in that answer. You also want to use gentle stretching and then isometric exercises. Return to competition should not occur until the individual is free of neck pain with and without axial compression, and also when range of motion and neck strength are returned to normal. And this decision should be made collaboratively with the team physician. So in the case of an athlete, I would oversee their stretching and pain and managing them every day. And then when we're ready to return to play, I would refer them back to the team physician. They would clear them for play, and then we're free to go. All right. Moving on to cervical strains on slide 10. Here we see all of the musculature of the neck, so I've included that in the picture for you all, so you can go through and look at those. You can strain any of these muscles. Cervical strains usually involve the sternocleidomastoid or upper trapezius, although scalenes, levator scapulae, and splenius muscles can also be involved. The same mechanisms that cause cervical sprains also cause cervical strains, and in many instances, these two injuries occur simultaneously. Again, signs and symptoms for a strain include pain, stiffness, and restricted range of motion. Palpation, however, can reveal muscle spasm and then increased pain during active contraction or passive stretching of the involved muscle. So these ones are a little bit easier to diagnose initially because the muscle is active. So if they're having pain activating their muscles, then you're going to know that the strain is more likely in that situation because the strain affects the muscle, and then if they're having pain with that contraction, then you know to look a little bit deeper there. You can also feel it with palpation. So management of a cervical strain would be cryotherapy, prescribed NSAIDs, gentle stretching, and isometric exercises of the involved muscle. Again, you can use a cervical collar for support and resolving those symptoms. Follow-up treatment may include continued cryotherapy or heat, again, whichever makes them feel better, as well as strengthening the neck muscles through appropriate resistance exercise. In the same thing, return to competition should not occur until the individual is free of neck pain with or without axial compression and when range of motion and neck strength are normal. Again, collaboratively with the team physician. They should see the team physician when the injury occurs and then again as a follow-up when they're returning to activity. Slide 11. We are looking at cervical spine stenosis. Cervical spine stenosis, structural spinal stenosis, is defined as a narrowing of the sagittal diameter of the cervical spine, or the cervical spinal canal, compared to the diameter of the corresponding vertebral body. So functional spinal stenosis is a more accurate measure of stenosis. Is defined as a loss of cerebrospinal fluid around the cord, or in more extreme cases, as a deformation of the spinal cord. This is documented using an MRI, sometimes used a contrast MRI, so they inject dye so that they can see more within the structures. And then as a result of the reduced cerebrospinal fluid, the ability of the spinal cord to decompress itself is limited, which can potentially lead to more acute and severe symptoms. Individuals may remain asymptomatic until a direct blow to the forehead or occiput produces neurological symptoms. Lateral blows causing rapid lateral flexion with or without rotation can also lead to acute symptoms, and that most commonly affects the cervical segments of C5 and C6. An example of this, I'm pretty sure that Peyton Manning has cervical spine stenosis, and that was one of the reasons that he needed to stop playing, was because of this injury. So signs and symptoms here. On impact, the individual may develop immediate quadriplegia with sensory changes or motor deficits in both arms and both legs, or all four extremities. So it can be both arms, both legs, or all four together. Sensory changes may include a burning pain. They can have numbness, tingling, or a total loss of sensation. Motor changes may include weakness or complete paralysis, with arm weakness being greater than leg weakness. The changes are always bilateral, differentiating this condition from a nerve root injury, which is always unilateral. So if the symptoms are happening on both sides, you can automatically rule out a nerve root injury and look more at the cervical spine stenosis. The episode may be transient with full recovery in 10 to 15 minutes, although in some cases complete recovery does not occur for 36 to 38 hours. This condition is often called neuropraxia because neural changes are only temporary. So management of the cervical spine stenosis is going to be, so structural spinal stenosis is discovered through routine radiographs, but MRI is often needed to determine the presence of functional stenosis. An individual who has had an episode of structurally related cervical spinal neuropraxia with or without transient quadriplegia is not necessarily predisposed to permanent neurologic injury. Individuals with developing spinal stenosis or spinal stenosis associated with congenital abnormalities have returned safely to participation. A lot of physicians now have concluded that individuals who have functional stenosis of the cervical spine with associated cervical spine instability should be advised to not continue in sports. So this one would be career ending in a lot of cases. And then because of the nature of the injury, if you're on the field with an athlete and they get hit and this is what you suspect, you activate EMS immediately. Spear tackler spine, we're looking at slide 12 now. Flexion of the neck, as seen in spear tackling, or the picture that I put on the slide for you, produces a straightened cervical spine that acts like a segmental column, predisposing the spine to permanent neurologic injury with further axial loading. Spear tackler spine originally was described in 1993 after review of data from the National Football Head and Neck Injury Registry. And the injury registry reported that 4 athletes who suffered from permanent neurologic injury had the following common characteristics. So these are what you would look for if you have an athlete that maybe this has happened to. Developmental narrowing of the cervical spinal canal, so we would need imaging to see that. Straightening or reversal of the normal cervical lordotic curves. We're looking at the curve of the spine maybe through an x-ray and seeing that there are changes there. Pre-existing minor post-traumatic radiographic evidence of bony or ligamentous injury, and then history of using spear tackling techniques. So this one is more repetitive if it's a hit that they're doing all the time, which they're not supposed to do. Then we'll use imaging to see if any of these other conditions are happening. Signs and symptoms here. So as with any catastrophic neck injury, the individual may develop immediate pain with sensory changes and motor deficits. And these deficits would be distal or away from the injury site. Sensory changes may include burning pain, numbness, tingling, or total loss of sensation. And then motor changes may include weakness or complete paralysis. Management of spear tackler sign, it can be kind of controversial, and that controversy definitely still exists regarding criteria for returning an individual to participation. But if you're on the field and this is happening, activating EMS. If you suspect a spinal injury, especially in the cervical spine, you will activate EMS immediately. The majority of neurosurgeons believe that the condition is an absolute contraindication for further participation in contact or collision sports. So if an athlete sustains this injury, they will not go back to playing football. They could run, they can do things that are non-contact, but they cannot go back to a contact sport. Moving on, let's see, we're on slide 13. So cervical disc injuries. These are less common in the cervical spine. We're going to look at them a lot more in the lumbar spine. Cervical disc injuries usually affect older physically active people. The primary mechanism involves sustained repetitive cervical compression, axial loading, or hyperflexion injuries during contact sports. Disc disease may be classified as either soft or hard disc disease. Soft disc herniation refers to an acute process in which the nucleus pulpus herniates through the posterior annulus. resulting in signs and symptoms of cord or nerve root compression. In sports participation, acute cervical disc herniations are thought to result from uncontrolled lateral bending of the neck. In contrast, hard disc disease refers to a more chronic and degenerative process with diminished disc height and the formation of marginal osteophytes. The condition usually begins early in life and proceeds through a series of defined steps preceding most, if not all, symptomatic disc herniations. So if it is a hard disc herniation, more than likely you won't know it until you start showing symptoms when you're older, which is why it affects older physically active individuals more than younger physically active individuals. Signs and symptoms here: individuals with degenerative disc disease and acute disc herniations usually present with varying degrees of neck or arm pain that can radiate into the shoulder or the arm. Pain is often exacerbated by the Valsalva maneuver. So this one is, we use it a lot to detect spinal injuries or pressure injuries. So you have an athlete or your patient sitting on the table with their legs over the side, just sitting normally and upright. You ask them to bear down, so they will kind of hunch over here, and you ask them to push really hard, kind of like they're going to the bathroom. And that increases the intrathecal pressure within the body, and it will exacerbate any neurologic symptoms that they're having. Then we have Sperling's maneuver, which will often reproduce sharp radicular pain. And that pain will go into the affected extremity in distribution of the compressed nerve root. We talked about Babinski's sign in Head and Face, we talked about that. So a positive Babinski sign is often present when the spinal cord is compressed by a disc like this. Severe cases may involve complete loss of motor function below the level of the injury, including arm and leg paralysis. Symptoms in the physically active population tend to be more pronounced because they notice it more due to the demands of their sport. Management of these disc injuries. Initial treatment for the majority of all herniated cervical disc injuries is to be conservative and non-operative. Treatment consists of rest, immobilization in a cervical collar for 1 to 3 days, activity modification, anti-inflammatory medication. You can use cervical traction, and then occasionally therapeutic injections are used. Therapeutic exercise can be instituted as symptoms improve, emphasizing isometric strengthening and cervical range of motion. And then after that, if everything is cleared, you follow it with sport and activity-specific exercises and drills. And then the individual may return to sport or activity participation once he or she is asymptomatic and has regained full strength and mobility. The picture on that slide is showing the nucleus and how the annulus and the nucleus are herniating into that space and then compressing the spinal nerve. All right, so then we are looking at cervical fractures and dislocations on slide 14. So unsafe practices such as diving into shallow water, spear tackling in football, or landing on the posterior neck during gymnastics or trampoline activities are what will lead to cervical fractures and dislocations from the axial loading and violent neck flexion. Some fractures, such as those of the spinous process or unilateral laminar fractures, may require only immobilization in a cervical collar. Other fractures, such as a bilateral pars interarticularis fracture of C2, or what's known as a hangman's fracture, may require a cervical collar or halo vest immobilization. So the picture on the slide there shows a small fracture. The arrow is pointing to the vertebrae where it is fractured there. So signs and symptoms. In sports, serious injuries commonly occur at the fourth, the fifth, and the sixth cervical vertebrae. Because neural damage can range from none to complete severance of the spinal cord, there's a range of accompanying symptoms. Painful palpation over the spinous process, muscle spasm, or a palpable defect indicates a possible fracture or dislocation. Radiating pain, numbness, weakness in a myotome, paralysis, and loss of bladder or bowel control are all critical signs of neural damage. If a unilateral cervical dislocation is present, the neck is visibly tilted toward the dislocated side, with muscle tightness resulting from stretch on the convex side and muscle slack on the concave side. So sometimes this, for the first time, we're seeing physical deformation from one of these spinal injuries. So management of these injuries. Because spinal cord damage can lead to paralysis or death, a suspected unstable neck injury should be treated as a medical emergency. An unstable neck injury should be suspected in an unconscious individual, an individual who is awake but has numbness and or paralysis, and also in a neurologically intact individual who has neck pain or pain with neck movement. Without moving the head or neck out of alignment, you can use cervical traction. But in this case, if I suspect a fracture and I have an athlete on the field, I'm not doing anything else. I'm checking their airway, their breathing, their circulation, and I'm activating EMS. On slide 15, we are looking at the brachial plexus and the conditions that go along with that. The brachial plexus is a complex neural structure that innervates the upper extremity, and it is typically damaged in two manners. A stretch injury can be caused when a tensile force leads to forceful downward traction of the clavicle while the head is distracted to the opposite direction. So you're looking at when an individual is tackled and subsequently rolled onto the shoulder with the head turned in the opposite direction. A stretch injury may also occur when the arm is forced into excessive external rotation, abduction, and extension. The injury usually affects the upper trunk, so C5 or C6 of the brachial plexus, which leads to a sensory loss or paresthesia in the thumb and index finger. A second mechanism of injury involves compression of the fixed plexus, and so you're looking at compression in that area. So the picture that's on there shows the brachial plexus and then the nerves that branch out of it. And then this also can be looked at in 3 grades, so grade 1, 2, and 3, and then that table is listed for you as well as what to look for in those injuries. There is a lot of things that can go along with the brachial plexus, and we'll look more at that and those injuries when we look at shoulder injuries. All right, so we are moving down into thoracic spine conditions. And so we're including the rib cage now. So the rib cage consists of the thoracic vertebrae, the ribs, and the sternum. The rib cage is essential for protecting your heart and lungs and for providing a place for your shoulder bones to attach. You have 12 pairs of ribs in your cage. Some ribs are true, some are false, and some are floating. All ribs are connected to the bones in your back, the vertebrae in your back. In the front, true ribs connect directly to the sternum. False ribs are connected to the sternum by costal cartilage. And then the last 2 pairs of ribs are called floating ribs because they remain unattached in the front. The floating ribs give protection to abdominal organs such as your kidneys without getting in the way of the space in your abdomen for your intestines. The sternum has 3 parts: the manubrium, the body, and the xiphoid. Your xiphoid process, which is a little notch that you can feel at the bottom of your sternum. I'm going over this part because it's going to be important for palpation in the next segment, but we're not really looking at a ton of injury here. So that was on slide 16. So moving on to slide 17, we're looking at thoracic contusions, strains, and sprains. So these ones we're going a little bit more together. And let's see. So the protective rib cage limits movement in the thoracic segment. However, the thoracic columbar junction is a region of potentially high stress during flexion and extension movements of the trunk, and then injuries to this area will include contusions, strains, sprains, fractures, and apophysitis. So on slide 17, we're looking at thoracic contusions, strains, and sprains, and these can occur from direct blows to the back during contact sports, and they frequently yield contusions to the muscles in the thoracic region. Those injuries range in severity, but generally are characterized by pain, ecchymosis, spasm, and limited swelling. So signs and symptoms here, the thoracic sprain and strain result from either overloading or overstretching muscles in the region through violent or sustained muscle contractions. So the sprain can happen in the back, the ligaments that are attaching in your vertebrae, and the strain can happen anywhere from back muscles and then any muscles in the front as well. So the presence of spasms make it difficult to determine whether the injury is actually a sprain or a strain, and so there's not a ton of testing that you can do here. And then dramatic improvement in a thoracic sprain will be seen within 24 to 48 hours. And then in contrast, severe strains will require 3 to 4 weeks to heal. So it's not for a little while that you'll see the difference here between a strain and a sprain, but it will be present in the healing process. So management of these contusions, strains, and sprains will be cryotherapy, NSAIDs, and activity modification. You want to follow up management, including superficial heat. You can use ultrasound. In this case, we can use massage and then appropriate stretching and resistance exercises as you're rehabilitating the individual. On slide 18, we're looking at thoracic spinal fractures and apophysitis. The rib cage stabilizes and limits motion in the thoracic spine, and in doing so, it lessens the likelihood of injury to this area. Thoracic fractures tend to be concentrated at the lower end of the thoracic spine in the transitional region between the thoracic and lumbar curvatures. Large compressive loads, such as those sustained during heavy weightlifting, head-on contact in football or rugby, or landing on the buttock area during a fall, can fracture the vertebral and plates or lead to a wedge fracture, which is named after the shape of the deformed vertebral body. I lost my spot. Again, if you suspect a fracture in this area, you're activating EMS or referring them to the team physician. There's really not a whole lot that you can do, especially stabilizing. You can backboard an individual, but if you backboard, you're activating EMS, and then they're probably going to re-backboard. And so in a case for what I do in sports is if I suspect a fracture or any kind of spinal injury like this, I don't backboard. I stabilize them until EMS comes, but after that, I let EMS take over, and I don't try to do too much. Okay, so we are moving into the assessment of spinal column or spinal conditions. We are starting on slide 19 now. And like I said before, there is a lot of injury that can happen here. There's a very the assessment here should not be rushed. It should not be it needs to be a little bit meticulous. There's the word I was looking for. And so you want to make sure that you're following good procedures here and making sure that you aren't missing steps. When in doubt, if you don't know, you should assume that the injury is severe. All right, so assessment. In a traumatic episode, if a fully conscious person is not experiencing severe pain, spasm, or tenderness, it can be rare that the individual has sustained a significant spinal injury. More than likely, the individual has experienced a minor injury, and which could be what we talked about, the strains and sprains. Even so, it's essential that that injury is assessed in a deliberate manner and taking as much time as necessary. The severity of pain and the presence or absence of neurologic symptoms, neck spasms, and tenderness will be able to indicate when a backboard and neck stabilization are needed. The individual's head, neck, or spine should not be moved, and the helmet, if they're wearing one, should not be removed. Those are things that can be saved for EMS, and there are ways to stabilize an individual on the field, even if they're wearing protective equipment. All right, so we're going to go through and look at how we talked about assessments before, but now we're going to apply it to these injuries. So you're taking a history. You want to make sure that you are taking a detailed history, information regarding their primary complaint, what hurts and why. That can lead you into learning about the mechanism of injury if it's an injury that you did not see yourself. You want to listen to characteristics of their symptoms and how they explain that to you. You're looking for disability resulting from the injuries. You also want to ask them if they've had any injuries previously to that area and if there's any important family history. So talking to your patient if they're alert and oriented is going to be very important. You're also looking for location of pain, and a lot of times with these spinal injuries, if they're having pain somewhere else in their extremities, more than likely if they sustained a hit or it's coming from the spine, then you have some nerve injury going on. Throughout this history, you're also testing their level of consciousness, their LOC that we talked about before, and looking at their long and short-term memory and listening to how they are answering your questions. You'll also be able to assess any changes that are happening while they're talking to you. Next, we're looking at observation and inspection. Observation should begin as soon as you look at the individual. Their body language can signal pain, disability, and muscle weakness. It is necessary to note the individual's willingness or ability to move, their general posture, how they're easing into motion, and then their general attitude at the time. Clothing and protective equipment may prevent visual observation of abnormalities in the spinal alignment. If it is appropriate, the individual should be suitably dressed so that the back is exposed. So for girls and women, a bra or halter top or a swimsuit can be worn. In the athletic training room, sports bras. That is what we require in this case. Observation should begin with postural assessment and then progress through a scan exam and gait analysis and then end with inspection of the injury site. So on slide, 21, I gave you a breakdown of a scan exam and what you're looking for. So the athletic trainer should instruct the athlete to perform the skills listed on this table. So during these movements, you're looking for signs of pain, hesitation to move a body part, or abnormal movement. If these signs are present, then you want to move on and complete a more thorough evaluation of the affected body part, and then if necessary, you will immobilize the area and refer the athlete to the physician. This scan exam is called a scan exam because it's a very quick way for you to assess a lot of things. Next, we're moving on to palpation. So these are the anatomical structures that you're palpating throughout the cervical and thoracic spine. There's a list there. You can go through and look at these anterior, posterior, and lateral. You can compare these to a skeleton or a picture if you want to, but I just wanted that list to be there for you. So this is what you would work through while you're palpating for any of these injuries. Again, if we were in class, we would pause now and do examples on each other. You would pick a partner and feel for all of these things, but unfortunately, we are where we are and we don't have that time. You could ask someone that you live with or someone that you are around and ask them if you could practice palpation on them. Always get consent when you're doing this, but if you're living with someone who's willing to be your practice person, that would be great. Next, at slide 23, we are looking at physical examination tests. So again, for this, there's a lot that goes into it. We're not going to be able to go through all of them. This is a basic intro class. So we are looking at functional tests, stress and functional tests, neurologic tests, and then activity-specific functional testing. So those are the four main things that we're looking at when we're getting ready to return an athlete to sport. This is what we go through. We will look specifically at functional tests, and more than likely this includes range of motion. So active movement or active range of motion and seeing what the athlete can do themselves. So I've listed there all of the range of motion that will happen in the cervical and thoracic spine. It also gives you the normal range of motion for all of those motions. Passive range of motion, the middle picture on the slide is showing how you would go through passive range of motion of the cervical spine. So the patient is lying on their back at the end of the table with their head off the table and in your hands. Until you have done this, you don't realize how heavy the human head actually is. So you want to be close, you want to hold their head in your hands, and what I will do is also I'll scoot really close to the table and I'll hold their head on my belly. And so I'm using myself to stabilize them as well if they're comfortable that way. And then the bottom picture, we're looking at resisted muscle testing. You'll go through the same movements as active movement, but then they're also in a seated position. And then the examiner will use one hand to stabilize the patient, and then you'll use the other hand to apply overpressure. And so in this case, the hand on the shoulder is just stabilizing the shoulder in the picture on the slide. And then the hand that is on the head is applying pressure. So you are pushing in one direction, and then the athlete is trying to stabilize and not let you push against them. So that is how you would test resisted range of motion of the cervical spine. On slide 25, we're looking at stress and functional tests. Again, we're not going to be able to go through all of them. I talked through the Valsalva maneuver. You guys looked at Babinski before, but there's a lot of tests that go into this. A lot of it you're looking for traction or compression, and we're mostly doing nerve testing. So I did want to highlight myotomes in this section and how to test selected nerves. So that is the table that's on the slide for you guys. When you move on into a grad program or a technical program, wherever you're going next, you will do all of these tests in a specific class. When I went through my undergrad, I did a quarter of upper extremity evaluation and then a quarter of lower extremity evaluation. And so these classes were extremely in-depth, and so this is really just scratching the surface for you guys. And then lastly, on slide 26, we're looking at rehabilitation. So the goals of rehab for cervical and thoracic injuries is relief of pain and muscle tension. You want to, let me find this really quick, make sure I don't miss anything. You want to make sure that they are able to be comfortable, even just in anatomical position, when they're sleeping, when they're sitting, doing normal activities of daily life. Making sure that they're comfortable in all of those. Next, you want to restore motion. Do they have normal range of motion in all of those things that we looked at on the last slide of active range of motion? And you want to restore proprioception and balance. And so, again, we talked at the beginning about how the spine runs through almost your whole body, and it's really protective and it's giving you stability to the rest of your skeleton. And so, making sure that proprioception and balance are back in order is really important for these injuries. And then you're looking at muscular strength, endurance, and power. Starting with isometric and then moving into more functional movements and building strength, building endurance. And this, again, at this point, we are working with the strength and conditioning specialist in order to progress them effectively. And then keeping their cardiovascular fitness is important as well, making sure that they're able to return to sport in the same or better fitness that they were in when they got injured. So that is cervical and thoracic spine. I will do a second video for lumbar spine. For your homework, you do not need to do one for cervical, one for thoracic, and one for lumbar. I just want you to do one injury for the vertebral column. So you can pick whichever region you want to be in, and then just one injury. You do not have to do one for every segment. You can if you want, but that's a lot of work, I feel like. So just one for all of the spine, even though there's 2 videos. I'm really liking what you guys are turning in so far. There's a lot of different ideas that I haven't seen before or ways of presenting your material, which is really fun to see. I am going through and looking at those, and I'm really enjoying it. Again, remember to let me know if you want yours to be shared with the class or not. And then I will do our lumbar spine, and that should be uploaded by tomorrow morning. Email me with any questions, comments, and just let me know how things are going for you. Hope you're well, hope you're healthy. I hope you're able to get outside and maybe enjoy the park or something at this point. And then, again, if anything is coming up throughout this quarter where you're not sure what's going on, please just reach out and let me know. Have a good day and stay safe.